This talk will focus on farmer and veterinary attitudes to antimicrobial usage and the practical implications of this. My name is Prof McDougall. I graduated as a veterinarian from Sydney University and after some years of practice undertook a PhD at the vet school at Massey University. I've had a 30-year career in cattle medicine, production and applied on-farm research. I'm a registered specialist in cattle reproduction with the Veterinary Council of New Zealand and have an appointment as an adjunct professor at the vet school at Massey. Cognosco, the research team I lead, is in the process of completing a 3-year study into antimicrobial usage and resistance in the dairy industry here in New Zealand. The research work that underpins much of this presentation has been funded by the Sustainable Farming Fund from the Ministry for Primary Industry in New Zealand, the Dairy Cattle Veterinarians of the New Zealand Veterinary Association, and by Dairy NZ. This presentation was developed for Agriculture Victoria as part of a wider project disseminating information about antimicrobial resistance as part of the Australian National Antimicrobial Resistance Strategy. The structure of this talk is to outline the problem of AMR, to outline some social science models that help us think about why farmers do or do not change, understand farmer attitudes and beliefs about AMR and antimicrobial use, provide some insights into what dairy cattle veterinarians think about antimicrobial usage, and finally provide some practical advice about how to engage with farmers. Sally Davies, England's Chief Medical Officer, stated in 2013 that antimicrobial resistance poses a catastrophic threat. She went on to say that if we don't act now, any one of us could go into hospital in 20 years for minor surgery and die because of an ordinary infection that can't be treated by antibiotics. A study undertaken by the Centers for Disease Control in the United States in 2013 estimated the impact of antimicrobial resistance in the USA. They estimated that 2 million people per year become infected with resistant bacteria, and of these, 23,000 people died, with the financial cost of these infections estimated to be $35 billion per year. In response to concerns about antimicrobial usage and resistance, governments around the world have developed strategies to combat antimicrobial resistance. The UK government produced such a strategy which has 3 key points. The first is improve the knowledge and understanding of antimicrobial resistance through better information and supporting data, and developing effective early warning systems. The second is to conserve and steward existing treatments by better prevention and control, and to develop resources to optimise use of antibiotics both in humans and animals. The third aims to stimulate development of new antibiotics, diagnostics and therapies so that new treatments can reach the market more quickly. An important part of the strategy is to change both consumer and prescriber behaviour. The question becomes, how do we change how animal owners use antibiotics and how we as veterinarians prescribe? One approach would be regulatory, or a top-down approach, which mandates certain change. However, a more effective approach might be bottom-up, whereby those making the day-to-day decisions, such as veterinarians and farmers, make more informed choices about antibiotic use. This takes us into the realms of human behaviour and social science. So how and why do we make the decisions that we do? So to give a practical example, we're all aware that drinking too much alcohol is likely to lead to consequences such as a headache. Yet despite this knowledge, some of us may overindulge. So why is this, and why don't we as humans always behave rationally? We all make what are apparently irrational decisions. Why is this? It may be truly a lack of knowledge about what we are doing. It may be a lack of motivation to change. We might know, for instance, that doing exercise is good for us, but not be motivated enough to get up and go for a run. Or it may be some kind of cost-benefit analysis. This latter analysis is not necessarily about money, but rather the perception of time or effort required relative to the perceived benefits. So the point is that it's not just about getting straight technical facts when we're making decisions. In the veterinary world, there's been a long history of farmer extension programs. In fact, the earliest agricultural extension programs date back to the 18th century. There have been many programs focusing on improving herd fertility or improving milk quality. Work done by Roger Morris and colleagues back in the 1970s demonstrated that such programs can change outcomes on farm. More recently, Tom Brownlee and colleagues demonstrated that introduction of the in-calf program to New Zealand did improve the 6-week in-calf rate. However, there's often been lower uptake than expected. For example, while hundreds of veterinarians in Australia and New Zealand have been trained to use in-calf, our experience has been that probably less than 20% of herd owners adopt the practices and approaches of in-calf. One of the reasons for this is the complexity of the interactions in a biological system such as a farm. Some research work undertaken by Jansen and Lam in 2012 made the point that on-farm change following implementation of a mastitis control program may not be as predictable as expected. This is partly because of the limits as to what can be measured in terms of our mindset and behaviour, but also because of external factors such as milk price, quota, weather, and other infectious diseases. The point being that it's easy to measure inputs such as the effort put in by vets and farmers to attend meetings or produce technical material, but it's harder to measure the changing mindset or behaviour, and hence ascribe the change on farm to this effort. The same research team looked at the factors that may motivate or prevent farmers or vets from making a change in behaviour. One model they looked at was the health belief model. This model has been used by social science workers in human medicine trying to encourage healthy behaviours. This model suggests that before we change our behaviour, we have to perceive that we are truly susceptible to a disease and that this disease has severe and significant consequences. So, for example, for a smoker to quit, they firstly would have to believe that smoking creates a direct personal risk, that is, that they are susceptible to lung cancer, and secondly, that if they get cancer, this has severe consequences for them. The second part of the model says that the person needs to believe that the suggested preventative behaviour is going to be effective. So they need to perceive the benefits of changing their behaviour, and they need to perceive that the barriers to a change in behaviour can be overcome. So returning to the smoking example, a smoker would have to believe that there are benefits to stopping smoking and that they can overcome addiction problems or the social environments that they are in. Another social science model is the theory of planned behaviour. In this model, the assumption is that behaviour change precedes any actual change. So using our smoking example, a smoker needs to stop smoking before there is any measurable improvement in health. And preceding the behaviour change, there needs to be an intention to change. That is, behaviour does not change randomly, but rather there is a conscious decision to change. The intention to change itself is affected by the attitude towards the behaviour. So for our smoker, they have to believe that smoking is deleterious to health and therefore they intend to change. There is also the idea of subjective norm, that is, the social environment and beliefs of those people around the person in question. So for example, if one's social circle includes a lot of smokers, then the norm for that group is to smoke. So to stop smoking is actually going against the social group, and this peer group pressure is very powerful. The final factor affecting the intention to change is the perceived or actual control. So given our understanding of the social science models, we were interested to understand what veterinarians and farmers understood about antimicrobial usage and antimicrobial resistance. So in collaboration with Dr. Niels Botha, a social scientist from Ag Research in Hamilton, New Zealand, the team at Cognosco undertook a series of social science studies assessing what farmers and veterinarians believed and intended to do about antimicrobial usage and resistance. One of the tools we used was to assess the knowledge, attitudes, skills, and aspiration, or KASA, of farmers. KASA models have been used in the social sciences since the 1970s. The logic was that if we understood the KASA, then we could measure change in these across time by repeating surveys. We could then see whether we were being effective in our communication and messaging. Secondly, by understanding where people's KASA were currently, we could design appropriate ways of communicating or intervening. We undertook 3 farmer focus groups, 2 veterinary focus groups, and 2 online veterinary surveys. The focus groups involved the use of structured but open-ended questions that were designed to elicit responses that could be interpreted in a KASA framework. Farmers clearly perceived that veterinarians were their primary source of information about animal disease and treatment. Veterinarians were seen as knowledgeable, and farmers valued the farm-specific advice that the veterinarians gave as a result of their interactions with the farmer. However, it was apparent that the farmer's personal experience and beliefs were very important. So, for example, when treating clinical mastitis, farmers accepted veterinarians' advice about the range of appropriate products, but the final decision about what to treat an individual cow with was based on personal experience. Personal experience was driven by the farmer's perception of clinical outcomes following treatment. So, for example, very few farmers in New Zealand and internationally undertake culture following treatment for clinical mastitis. Hence, they have no way of measuring bacteriological cure, so they use resolution of clinical signs such as changes in milk or reduction in heat and swelling of the mammary gland as their primary outcome. But resolution of clinical signs does not necessarily mean that bacteriological cure has occurred. Farmers also valued efficacy at a fair price over price per se. So if the treatment was effective, they were willing to pay. Farmers also wanted clear protocols for treatment and for when to change treatments if clinical signs were not resolving. Not surprisingly, farmers made decisions in the context of the disease status of the herd. So, for example, decisions about whether to use whole herd dry cow therapy were based on the current bulk milk somatic cell count and clinical mastitis history of the herd. One of the tenets of prudent antimicrobial usage and good stewardship is knowledge of the pathogen and its likely sensitivity. However, farmers rarely use microbiological culture. The reasons for this include the fact that there is a time delay between sampling and results being reported, in which time the cows are already treated. There is a perception of high costs and of logistics issues, that is, collecting and delivering samples. There was also a perception by farmers that culture rarely resulted in a change in the treatment recommended by veterinarians. It became clear that farmers often collected milk samples in cases where there was an apparent failure of therapy, and hence their expectation was a recommendation for a change in treatment. So the assumption by farmers was that if clinical signs persisted, this was due to resistance or inappropriate drug choice, and there was very little understanding that apparent clinical failure could be associated with factors associated with immune function of a cow or pathogenicity of the bacteria. To get a more quantitative assessment of farmer perceptions, we provided farmers with a list of potential reasons for selection of particular antimicrobial and then asked them to rank these. What we found was that the veterinarian's advice was the primary basis of antimicrobial selection, with 87% of farmers stating the vet's advice was the first reason for choice. But this was closely followed by their own experience, with 67% of farmers ranking their own experience equal to or superior to veterinary advice. Thereafter, factors such as research data, price, withholding period, and convenience were not highly ranked. We asked farmers to rank their responses on a 1 to 5 or a strongly disagree to strongly agree scale to a series of statements about antimicrobial resistance. The majority of farmers, 79%, agreed or strongly agreed that there is a risk of antimicrobial resistance developing in dairy cows. They were neutral or disagreed with the statement that the risk of antimicrobial resistance development in humans is small, and a minority of farmers agreed or strongly agreed that their use of antibiotics on farm could cause AMR on their own farms. They strongly disagreed that usage on their own farm could cause antibiotic resistance on other farms, and similarly, the majority strongly disagreed or were neutral about a statement that AMR on their farm could cause resistance in humans. They were neutral or agreed that vets are responsible for ensuring that AMR does not become an issue. 84% of the farmers agreed or strongly agreed that they needed antibiotics on their farm. Surveys of prescribing by dairy cattle veterinarians found, not surprisingly, that veterinarians primarily thought about spectrum of activity, withholding period, and duration of activity of antibiotics when prescribing. Vets considered the animal's clinical signs and history and likely pathogens when prescribing. 2/3 of the veterinarians said that they sometimes collected samples for culture, but less than a third ever performed sensitivity testing. Veterinarians also considered farm-related factors such as their own experience of response to therapy on that specific farm, as well as their knowledge of disease history. Veterinarians responded to client views of efficacy or the client's preference for an antibiotic. Other factors veterinarians considered were their own training, cost-benefit, and practice policies. Less than a third of the vets reported that there was a formal antibiotic usage policy within their practice. A clear outcome of the studies was that farmer experience and perception of response to antibiotic therapy is a key driver of their own treatment decisions. The farmer's experience and preference also influence veterinary prescribing. One issue here is that farmers are making decisions based on subjective assessment of clinical signs, with all the associated biases. Vets were asked to rank a series of statements about antibiotic usage and resistance on a 1 to 5, that is, a strongly disagree to strongly agree scale. A total of 170 veterinarians provided responses to the survey. Only 41% of veterinarians agreed or strongly agreed that antibiotics are a diminishing resource, and 57% agreed or strongly agreed that the risk of AMR was being overstated by authorities. Only 46% agreed or strongly agreed that AMR risk on farm is real, and just over half agreed that AMR is a risk to the community. However, a great majority of vets, more than 90%, agreed or strongly agreed that they consciously think about the label indications, withholding periods, and any off-label use of antimicrobials. 60% of veterinarians agreed or strongly agreed that animal health companies actively marketed new antimicrobials. Only 41% of vets agreed or strongly agreed that they may lose a client if they refuse to prescribe an antibiotic. Even fewer, that is 28% and 27% respectively, agreed or strongly agreed that practice owners or employees put financial and business goals above managing the risk of antimicrobial resistance. Just over 3/4 of the vets agreed or strongly agreed that vets generally prescribe responsibly. And finally, 87% of vets agreed or strongly agreed to the statement that farmers lack an understanding of antimicrobial resistance. Analysis of the veterinarian's response to the questionnaire found that responses were affected by the age, gender, and role in practice. So, for example, younger vets were less likely to agree or strongly agree with the statement that the risk of antimicrobial resistance is overstated by authorities. Male vets were less likely to agree or strongly agree that AMR on farm was genuine, and more likely to agree that AMR risk to staff on farm is small. Finally, owners were more likely to agree or strongly agree that AMR risk to staff is small, and were less likely to agree that practice owners would offset business profitability or goals against the risk of antimicrobial resistance. So, having outlined some of the drivers for farmers and veterinarians to make decisions about antibiotic use, the question becomes, how can we effectively communicate with farmers around these issues? The research group of Jansen and colleagues have looked at the way that veterinarians communicate with farmers. What they have suggested is that there are a number of steps required to get effective communication and change. Firstly, there needs to be a structured approach to the discussion. So, for example, there needs to be an opening, an assessment of the goals or needs of the farmer, and a follow-up of any previous actions or interactions. They also suggested the use of active listening principles. That is, listening, paraphrasing back to the farmer what they've just said, and asking open-ended questions to really understand what is behind the farmer's thinking. They advocate the use of so-called SMART goals. That is, defining actions as specific, measurable, achievable, realistic, and time-bound. And finally, they make the point that to be effective, the interaction needs to be peer-to-peer, not a top-down process. What this means in practice is that the interaction between the farmer and vet is balanced in terms of time and content. So the chance we'll get uptake of new ideas or change of behaviour by farmers is enhanced where we understand the beliefs, the peer-to-peer pressures, and the perceived or actual barriers to implementation of change. The health belief model and theory of planned behaviour help us to really understand why farmers may or may not adopt and implement what appear to be very rational bits of advice from the veterinarian. So in conclusion, antimicrobial resistance is a significant problem both in human and veterinary medicine. There is broad agreement amongst health authorities internationally that changes in antimicrobial usage and hence in the risk of antimicrobial resistance are required. To achieve changes in AMU, there needs to be a change of behaviour and a change in the knowledge, attitudes, skills and aspirations of both farmers and veterinarians. The recent research work undertaken in New Zealand suggests that the majority of farmers do not perceive a link between antibiotic use on their farm and the risk of antimicrobial resistance, particularly in the wider community. So using the health belief model, farmers do not perceive any personal threat around antibiotic usage and hence are unlikely to change their behaviour. So there is going to be a need for ongoing discussion with farmers and their organisations about risks of antimicrobial resistance and hence the need for potential changes in how antimicrobials are being used on farm. Finally, messaging about antimicrobial resistance needs to be personalised, relevant and not too abstract. Thank you for listening to this presentation.